All right, chapter 16, general pharmacology. We're going to talk about some medications, what EMTs can give and can't give, and some of the different things we need to look at when we give medication. One of the big medications that EMTs can give is oral glucose, so we're going to look at that quite a bit. We'll talk about quite a few things though. Make sure you're ready for your next test. So, the big thing, medications EMTs can administer. You can give, these are medications we have on the ambulance. We have aspirin, oral glucose, oxygen. Some services still carry activated charcoal. We do not here at JCAT. So aspirin. Aspirin is administered to patients with chest pain of a suspected cardiac origin. Okay, so anybody we think has chest pain that could be cardiac, we're going to give baby aspirin to. We just have them chew that up. We'll talk about that here in a little bit. Oral glucose. Going to help a patient with diabetes or low blood sugar. Okay, so we're going to check their sugar like we talked about in class last week, and then we can give them some oral glucose as long as they're conscious and alert. They have to be able to swallow. They have to be conscious. They can't be unresponsive. You can't rub it on their gums. That's not going to work. Okay, that could be an aspiration risk. Activated charcoal. Often used in poisoning cases. We don't carry activated charcoal here. It is theoretically something that you could give. Bronchodilator, prescribed inhaler, can help with respiratory problems. We're going to talk more about when you can give or assist with this. Prescribed medications, inhalers, nitroglycerin, epinephrine, all things that prescribed by a doctor that you can assist with in the right situation. So, bronchodilator inhalers. They're used in patients with asthma, emphysema, chronic bronchitis. It enlarges constricted breathing tubes. Side effects, a little bit of increased heart rate, a little bit of jitteriness. Big thing with this, obviously, is that you're going to be assisting patients that have these prescribed to them. It's not necessarily something that you're going to be giving to anybody. And the increased heart rate, if it's fixing the breathing problem, if you're hearing them wheeze real bad, if it's fixing the breathing problem, it's going to be a good thing. So we're not going to worry too much about that heart rate. Only time this really comes into effect is like a cardiac patient that is having maybe chest pain and difficulty breathing and wheezing, and their heart rate's already elevated. We don't want to make it worse. So that's something we watch out for. Here's nitro spray. It's often prescribed for chest pain. We're going to talk about the indications and contraindications for nitroglycerin. Okay, it's taken by patients with a history of chest pain or of cardiac origin. It helps dilate. They're going to expand. Those coronary vessels are going to enlarge. So if there's a blockage in the middle of that coronary vessel, we're going to be able to open that up, and that blockage is going to stay, but the blood's going to flow around it. Contraindications big time here. Low blood pressure. We're taking medications for any kind of erectile dysfunction. Okay, so Viagra, Levitra, Cialis, anything similar. It's going to drop that blood pressure in a dangerous way. So we have to be careful and make sure that we do not give nitro if they have a low blood pressure or if they're taking any of those erectile dysfunction medications. Epi auto injector, and it's good for severe allergic reactions. We handed these around in class, last class, but so you got to see these. Like Tina was telling you, straight to the thigh works, or the buttocks, or whatever we need to do to get it in. Okay? Prescribed and used for patients with severe allergic reactions, classified as anaphylaxis. Epi is a vasoconstrictor. It relaxes the smooth muscles in the airway passages. So it's going to do a couple things there. All those vessels are going to clamp down. So what an allergic reaction does is it makes you kind of swell all over, right? Everything's dilated, everything's irritated. You got a lot of histamine release. Epi's going to come in there and vasoconstrict and lock those vessels down to help you be able to perfuse it and breathe and all that good stuff. So we only use this for anaphylaxis, right? When the airway is swelling shut. Otherwise, we don't use it. Some side effects, we're going to have increased heart rate and blood pressure. So we do have to monitor those, but once again, it's going to be a situation where if we don't get the epi into them, we're going to have a real problem. If we don't get the breathing issue controlled, they're going to be worse off. So yeah, the side effects, we're going to tolerate those side effects because we absolutely have to keep them breathing. Okay? Other drugs that can be administered in some areas, right? Narcan, it's an antidote for a patient who's unconscious and respiratory failure after taking a opiate. Doesn't work if the patient has not had an opiate, right? Force protection medications, atropine, auto-injector to treat responders in the event of an attack. This is post like a chemical attack or a chemical exposure. So oral glucose, showing you how to administer it. You can kind of rub it in there. Once again, they have to be awake and alert. I normally just have them stuck on the tube. It's probably the easiest way. So we're going to kind of talk about each drug a little bit more in depth and when to give it, when not to give it, all that good stuff. So each drug has at least 3 names. They have a chemical name, a generic name, and a brand name. Okay, and this is pretty tricky for a lot of people because it depends on the situation on what name's used and what name you might know it by. It may be different for each medication. One or more trade names given to the drug by manufacturers under the brand name, right? So that can be very challenging to keep these straight. So what you have to know before you give any medication to any patient, you have to know these things, right? You have to know the indication, what should I give it to this patient, the contraindication, why should I not give it to this patient, what side effects should I watch out for, and what untoward effects could there be as well. What effects that they may not like, may not be side effects, but unexpected consequences kind of things. So, what form of the medication? There's different forms of medications we give. We give compressed powders or tablets. We give liquids, gels, suspensions, fine powder, gases, sublingual sprays. We can give things IV. There's different routes of administration. We have a lot of options, right? Now, as EMTs, we're not going to be giving anything IV, but there's a lot of things out there. So there's sometimes we're administering. Some medications we can administer, and some medications we can assist with. And so you need to know the difference between when we're administering, what we're assisting with. You have to know the medication, and you have to use good judgment on what you're doing. If you don't know something for sure, you shouldn't be giving it. It's just not a good idea. So, offline medical direction, we do not have to speak to a physician. These are standing orders. This is a test question, right? So, standing orders are the same thing as offline medical direction. Online medical direction is when we actually speak directly to a physician. So we call them up and say, hey, doc, this is what I got. This is what I got going on. Maybe it's a cardiac arrest. We've been working for 30 minutes. We want to know what you want us to do. Or, hey, this diabetic, he's not acting right, but I'm not sure he's low enough. He's like right at 65. Should I give him some oral glucose or should I not? That would be online medical direction, okay? You listen to the order and then you repeat it back and you ask for clarification if necessary. Offline is, I have a protocol that says if they're under 68, I'm going to give them oral glucose. So that's what I'm going to do. I don't have to call for orders. So those are the differences there. Make sure you know those. So the 5 rights, I believe this is a test question as well. Do I have the right patient? Is this the right time to administer the medication? Is this the right medication? Is this the right dose? And I'm giving it by the right route. So let's use oral glucose as an example. Do I have the right patient? Well, yes, this is my only patient. This is the only problem I have. Is it the right time? Well, yeah, his sugar's low. We haven't given the medication in the last 5 minutes. So yes, it's the right time. Is it the right dose? Well, yeah, double check that, make sure that's right. Now, I'm giving this by the right route. I'm not, giving it to them IV as oral glucose, right? I'm giving it to them orally, and the patient's conscious and can take this. So, yep, it's the right route. It's the right. I got my 5 rights. I'm good to go. Potential risks, if you don't check these, you could give an expired med to a patient. You could double dose them. Maybe somebody else just gave them that medication. You didn't necessarily know. You didn't check with your partner. Now you've given it to them twice. There's a lot of things that can happen if you don't check these. Maybe if you have multiple patients, if you're working more in an ER or hospital setting, you give to the wrong med to the wrong patient. Well, now you've really caused a problem. So you have to be careful. You have to make sure you check your routes. Here are your rights. So routes of administration, you can have oral or swallowed. Sublingual is dissolved under the tongue. Inhaled is breathed in. Intranasal is sprayed into the nostrils. Intravenous is injected into the vein. Intramuscular is like how you get your shots. It's IM. It's going to go into the muscle. Subcutaneous is just under the skin. This was always hard for me. So intramuscular, they're injecting it into the muscle. Subcutaneous, they're going at a very shallow angle and just getting it underneath the skin. Intraosseous is going into the bone, and endotracheal is sprayed into the tube. This is an older school method. Now that we have intraosseous, we don't really use endotracheal, and it was highly ineffective. I know you guys like my stories, so one time as a medic student, we had just intubated somebody, and the paramedic had shanked the IO, and so we were given medications. She's like, just shoot down the tube. Let's do endotracheal. So we're bagging him, and I have an EMT partner there, and he bags him, he takes it off, and I shoot down the tube, and they're doing compressions, obviously, it's cardiac arrest, and it shoots back up into his eye. So not a very effective thing, and I didn't use the med port because I was a dumb medic student that didn't know what he was doing. So be careful, and it's not a good route. We really don't use it anymore. We use the other routes. So some pharmacodynamics studies the effects of medications on the body. What effect will the medication have? How will this medication affect my patient specifically? What patient-specific factors change how medication works? So, you know, if I'm a diabetic, is oral glucose going to work as well? Yeah, it'll work fine, but they may be insulin resistant, or you know, your COPDers, what effect is oxygen in high quantities going to have? Well, yeah, eventually it could kill that hypoxic drive we talked about. So we do have to know all these things. So after administering the medication, we always reassess. We got to document those medications and those reassessments. Always want a baseline vital signs and then a post-medication vital signs. So if we give oral glucose, we want to double check it. Here's some medications patients often take. They often take Advair. Advair is a medication that's prescribed to a patient for daily management of respiratory disease. Should not be used for emergency treatment of asthma or breathing difficulty. So you may have to assist in IV therapy. And there's different ways that we can do that. There's a saline lock. Catheter is placed into a vein, and they just put a lock at the end of it. The lock contains a port for administering meds. Traditional IV bags, so we're going to show you how to spike IV bags, hopefully on your clinicals. Hangs above the patient, constantly flows fluid and medications into the patient. There's clear plastic tubing connecting fluid bag to a needle catheter. There's a drip chamber, a regulator, and a drug or needle port. And then an extension set, we use those a lot here. They go directly to the catheter and make it a lot easier to disconnect the IV line and still have an IV in place so we don't accidentally pull it out or anything like that. So we use those quite a bit. So you should inspect the IV bag, make sure it contains the solution that was ordered, because there are different solutions. So normal saline is used quite a bit, lactated ringers is used quite a bit, but you know, there's also, you know, D10, right? We don't want to give somebody a bunch of sugar if they don't need it, right? We got to make sure it looks clear, it's not yellowed or anything like that. We want to make sure it's in good shape. So then you're going to remove the cap off this needleless port here. You're going to spike the bag into the fluid bag. We're going to open that flow regulator, and we're going to squeeze this chamber, okay? And squeezing that chamber allows it to fill about halfway full. And then we're going to flush the line. So we're going to turn on the flow. We're going to leak a little bit out into a trash can, get the air out of the line. Air into a patient can be extremely dangerous, can be deadly. A couple small bubbles of air is not the end of the world. However, a large amount of air can kill a patient. So, if you're having problems with the line flowing, you want to check the line, make sure there's nothing, no major kinks or anything like that. You want to make sure that there's none of the locks are shut off. There's a lock on your extension set that can be closed, or your roller clamp could be closed. Could be part of it. Sometimes it can be pinched in like the cot where the arm section comes up, or it can be pinched off by a backboard or something like that. The medic will adjust the flow rate as needed, and then you always want to monitor that site as you're taking care of your patient. If somebody else has started that IV and now it's closed off, just to make sure it's not swelling or looking like it may have infiltrated. So, aspirin, oral glucose, and oxygen are medications carried on the ambulance that the EMT may administer to a patient under specific conditions. Prescribed inhalers, nitro, and epi auto-injectors are medications that, if prescribed, the EMT can assist the patient in taking. You may be able to administer naloxone or Narcan in certain states. You may need permission from medical direction to administer or assist the patient with a medication. So it's all dependent on the local protocols, but these are kind of the national guidelines. So wide variety of medications that a patient may be taking. It's hard for us to learn all these. Even as medics, we have a challenge trying to learn all these, but it is a beneficial thing for us to try and do. If we know what meds they're taking, we can get a better idea of their medical history and conditions. If we can figure out what medications patients are taking, we can report this to the hospital, try to get them a better picture of what's going on with these patients. This main thing, we can administer aspirin or glucose and oxygen as part of patient care. We can assist with prescribed inhalers, nitro, and epi auto injectors. So assist means assisting the patient who is able to do that to an extent. We need to know the names, indications, contraindications, and the 5 rights. And I think that is a test question, so make sure you know that. And then reading, assessment, and documentation are important elements of our medication administration. So, that is chapter 16. Thanks for watching, guys.